Next presenter is Dr. MD Arifur Rahman.
Honorable Chairperson, learned audience, good morning. I am Dr. Mohammad Arifur Rahman. Welcome you all in this August gathering. So my title is New Wine in Old Bottle, Bifurcation Dilemma. Our patient, Mrs. 60 years old, diabetic, hypertensive housewife, admitted with compressive chest pain for 10 hours. She mentioned there was exertional chest pain for last 1 week. It relieved on rest, but this time, this was persisting even on rest. This was her ECG. There was a significant STT change in anterior leads. Her troponin was positive, blood sugar was 10. Ejection fraction was 62%. This was her ECG, angiogram, and there was significant pressure drop when engaging the left main. That's what immediately disengaged done. So we can see there was left main osteal disease and along with LAD osteal proximal, and there's also plaques up to the proximal segment of LAD. There's also narrowing in the L6 ostium, but it was insignificant. So her syntax score was 19. We planned for PCI. We take a 6-month EBU guide. Initially, we had the L6 and LAD. Predilation done with a 2.5 12 minute left main and LAD proximal both segment. After predilation, so it took a 3 into 38 millimeter disc covering the proximal segment of the LAD also, cross over the L6. Considering all the aspects, we planned for a single stent strategy, as we thought there was no significant lesion in L6 ostium. So with all the ways so that we don't miss any geographic region in the left main and cover all the disease segment of L proximal LAD also. After that, we post dilation done with 3.5 into 12 NC balloon. And we can see there was significant narrowing in the L6 ostium. So we took another small balloon and cross the L6 ostium and predilation done. And we also done kissing with 3.15 in the LAD and 2.5 into 8 millimeter L6 stent. And pot done with a 4 into 8 millimeter NC balloon. So this was the final result. And we were quite happy with the result. Angiographic result is satisfactory. So we complete our procedure and put the patient in post-cath. If we think about the strategy, we all know that provision of one stent is based considering the all-cause mortality and other parameters. But just after 1 year, she again admitted with severe chest pain. This time her troponin was again positive, so again we planned for an angiogram, check angiogram. But we was very much disheartened with the result. See, there was a critical stenosis in the L6 ostium. This point was kept in our mind that this patient may came again with the L6 stenosis, and this thing actually happened just after 1 year. So now we have to plan what strategy will be best for him, considering every aspect, the angulation, the size of the L6. We planned for intervention of the L6 ostium. We took a 2.5 millimeter balloon and predilation done of the ostium. Then we took a 2.75 into 18 millimeter regulating stent, crossing the lesion, and just protrude in the LAD stent, left main to LAD stent. We also take another balloon in the left main to LAD so that the protrusion is not very much, so that the stent load is less and lesion cover is maximum. So we planned accordingly and we did this. See, we pull the stent just in the left main to LAD stent. We placed it and kissing done. Along with kissing done, the same balloon in the L6 and another balloon in the left main to LAD. After kissing, we did pot with a 4 into 8 millimeter balloon. So this was the views of the kissing and pot. And this was the final result. So So we can see here it is a satisfactory result. So in selected cases, provisional single stent approach for distal left main bifurcation is preferred as it is associated with more favorable outcome. But this does not happen always in our case. Incorporating with FFR and IVAS during bifurcation PCI helps a lot in decision making and selection of the techniques. In case of side branch restenosis, among the available technique, TAP is a very smart option as recrossing is easy and lesion missed may be avoided. Thank you. Thank you for patience hearing.
Any comment, please?
Sir. Sir, that was not available, sir.
Actually, imaging should be done in case of
Exactly, sir.
bifurcation, and you could have pressure study of the LCX as it was a
Exactly.
doubtful lesion.
Sir. Left main to LED.
And you adopt a tap technique.
Right, sir.
Tap or nano crush.
Sir, it's a tap because
you inflate the left main.
yeah,
LED
we
balloon or not?
inflate the left main so that
Now, why you keep under in a normal balloon, under inflated balloon in the
so that the protrusion is minimum.
movement to reduce the movement of
Reduce
the
movement
branch.
plus the protrusion. Both is under control.
If you control the protrusion, if you need to inflate the left main LED balloon,
Right, sir.
so that you make so that you can see there is a indentation in the left main LED balloon,
Right,
and
sir.
it is the benchmark trial of the one of the nano crush technique.
So as the left main to LED is a big dia vessel, and when we protrude the L6 stent, there is a most chance of the protrusion is more. Another thing is the mobility, so that we cannot fix the stent. If we partially inflate the left main to LED balloon, the system become fixed, and the procedure becomes very easier. We can pull the stent according to our assessment, and we can fix it according to our plan.
Thank you, but still it is good to inflate. If you want to reduce the movement and fix the coverage of the ostium of the, it is better to inflate the left main LED balloon in one or two patients.
Right.
So
Just
that
one quick
because
comment. Just
other-
one quick comment. Just one quick comment. I think it's a fantastic case. You've done quite well, and it shows the L6 ostium is always a troublemaker. Just points from my side. If the angle would have been less, like it's a good wide angle, 90 degrees, would you have changed your strategy? And the second one, because the patient's coming back after 1 year. So the stent is already endothelialized in the left main and the LED. Would you consider a drug-eluting balloon there so that there is no restenosis? Just two questions, that's it.
Yeah, when we see there is a narrowing in some cases, on the seams there is significant, then we use the balloon routinely. Another thing is if the angulation will be less, then mini crush should be a very good option.
Yeah, Dr. Arif, the first thing is that pre-dilate in a left main bifurcation PCI, pre-dilate the branch, the side branch, which you don't want to stand, or you go for a provisional philosophy. Pre-dilatation of the side branch is very dangerous. And it has happened in EVC main, that they didn't pre-dilate, but they have done a mandatory kiss.
Right, sir.
When even a provisional philosophy was there, one stent strategy, but they have done a mandatory kiss. And what has happened? 22% of that provisional one has turned into a bailout two stent strategy.
Right, sir.
So better not to pre-dilate it, better not to dilate the side branch if you see a TIMI3 flow. And angiographically whatever it is, and what Dr. Jamil said, you can at least a maximum, you can go for a FFR and you can see that one. So pre-dilation means already you have injured that one, so you can expect that it will come out with a restenosis.
We also think so that dilatation after narrowing is the provoking factor for the L6 stenosis.
That's I'm telling. So don't do that dilatation in the
Yes.
side branch if you don't want to stand it. Rather, if it is a TIMI3 flow. If you see that there is no TIMI3 flow, TIMI2 flow there, then you have to go for, at that moment, the first time, you have to go for a two-stent strategy.
Two-stent strategy, exactly,
So forget
sir.
about that one, the first thing. The second thing is that when later on you have done one, Dr. Amol has told the true thing, that nano crush, especially the Shrivanan Roy's nano crush technique, because two nano crush techniques are there, Morris from Canada and Roy's technique of nanocrush. Roy's technique is telling that you have to take a 1 millimeter or 0.5 millimeter less calibered balloon in the left main, which you have kept there.
Right, sir.
And you have to inflate it in a nominal pressure, and with that, which I like also, because
Right,
I like
sir.
nanocrush very much. So, and keeping it, that balloon in the inflation, then pull the stand in the LCX. Then it will be a controlled pulling of the LCX stand, but you will see it will stuck somewhere. So it means that it has touched the balloon and it will never be over. That means overhanging of the stand in the left main.
Exactly. We
Because
are also
tap-
facing problem the placement of the L6
Yes,
in this
that's
case.
the thing. So because
Yes.
at that moment when you are doing that one, only keeping the balloon means what? That then later on, if you protrude the stand in the left main, that balloon will help you. That somehow
Exactly.
it will end up with a crush technique. That too much protrusion in the left main, you have to crush it, then you have to go for a decay crush.
Exactly, sir.
Right? So it's better to keep the balloon. That is Ray's nanocrush technique, which Dr. Omar was telling.
Yeah.
So it's better for this sort of, because left main in a huge area. You can
Huge
do
area.
anything.
And
You can
there is huge
manipulate
movement.
everything.
Huge movement was there along with
There
respiration.
also, and lot of devices you can take there. It's a beautiful place to do a PCI.
Thank you very much.
This is a very voluminous, very voluminous.
Thank you very much. Next presenter.
Yeah.
Mass will be increased as well as restenosis will be increased.
Exactly,
Very
sir.
careful about the left main bifurcation.
Thank you,
Thank you,
Dr.
sir.
Arif. Thank you.